Okay, hello everyone. Again, we are back with a different topics and with the seminar too. Our today's uh, our today's discussion will be about a Clostridium difficile. So as we have discussed before about previously with a Clostridium tetani, today's we have chosen the topic of Clostridium difficile. So what's Clostridium difficile? What type of microorganisms? How it's clinically present and how we do manage this Clostridium will be Clostridium difficile will be our next point of management. So Clostridium difficile is one of the gram-positive microorganisms that you can find as a normal flora in your gastrointestinal system. So it is a gram-positive. It is a gram-positive microorganism and it is known for its spore forming. This Clostridium difficile has more than 60 species that currently known, and it is a non-anaerobic microorganisms. So Clostridium difficile is basically famous for one thing, because this Clostridium difficile, it is one of the most common cause of health care associated infection or hospital associated infection. So it is most commonly known for its hospital associated infection. So if you take as an example from the Clostridium difficile infections, around 3% comes from the community and around 20% come from the hospital. And it, as I mentioned before, it is a normal flora of the GI system. It is a normal flora of the GI system. So how, if it is a normal flora of the GI system, it's supposed to be asymptomatic. So why it causes clinical manifestations? So normally normal floras in our guts usually present as a balance. There is a balance. One microorganism did not dominate the other ones. The same works for the Clostridium difficile. So for example, when the patient is taking in hospital like a broad spectrum antibiotics, these antibiotics basically kills the normal flora. So it gives a chance for this Clostridium difficile to replicate itself and to cause its harm. There is a term called Clostridium difficile associated diarrhea. This Clostridium difficile associated diarrhea, it is a major health care problems that basically patients on broad spectrum antibiotic usually presented with this thing. So this is the most common cause of diarrhea in hospital, and especially it is more prominent for the new ones rather than carriers. The CDiff or Clostridium difficile acid, it is the most common. It is especially in the medical world, you may have it. So what is the pathophysiology or how Clostridium difficile causes clinical derangements? So Clostridium pathology. So Clostridium difficile basically has two important toxins that plays a crucial role in its pathophysiology. So the first one is toxin A, and the second one is toxin B. This toxin A is enterotoxin, and this toxin B is cytotoxin. So enterotoxins infect the enterocytes and it makes increased GI secretion because there is inflammation. It causes GI secretions by causing inflammations. But in the case of toxin B, it disrupts the cytoskeletons. So epidemiological wise, as I mentioned here, it is most common in hospital acquired pneumonia. So what are the risk group to develop this kind of Clostridium difficile infections? The first one is patients on broad spectrum antibiotic. The other one is all patients, age less than 65 patients. Another one is immunocompromised patients. What are these immunocompromised patients? Like diabetes mellitus, HIV/AIDS, patients with prolonged of steroids, they could have presented this. Another and most important one is patients with chronic use of proton pump inhibitors, like for the case of dyspepsia, they might use it because we are suppressing the acids. We are creating a favorable environment for this Clostridium difficile antibiotics. When I say this broad spectrum, as I say, we have different broad spectrums, but the one which is linked to Clostridium difficile associated diarrhea or CDiff it is clindamycin. Clindamycin is the one it is highly related with this. But another important broad spectrum antibiotics are like penicillin, like cephalosporin, and like fluoroquine. These are also another known spectrum of antibiotics that are related with CDiff. So what are the clinical presentation of Clostridium difficile? So normally it could be asymptomatic at normal despite its significant replication or colonization in the gut. It could be asymptomatic. The other one is it could have mild to moderate symptoms. Like it could have a watery diarrhea. If the patient is admitted presented with a watery diarrhea for more than 3 episodes and they are non-specific or non-diagnostic for a neonatology, the likelihood of this Clostridium difficile cystitis it is very high. Another one is if the patient has this abdominal cramp. The patient could have low-grade fever. And most importantly, these patients are known to have this leukocytosis. So, for at least the patients with watery diarrhea and leukocytosis, the likelihood to be cystitis it is very high. The other one is in the case of severe case. In the very severe cases, all are presented, but what we add here is the patient temperature or the fever will be extremely high. The other one is the number of WBC or leukocytosis will be high. Sometimes it could go beyond 15,000. And this patient, because of this frequent watery diarrhea, they will develop this AKI. So creatinine is usually elevated in this case. And the last one is there will be hypoalbuminemia. Hypoalbuminemia will be present. So in the case of fulminant type of fulminant type of Clostridium or C. difficile infections, in the case of fulminantes, the patient could have megacolon, big colon. The patient have ileus, and they could have perforations and develop peritonitis. And they may end up with death. So how do you diagnose Clostridium difficile? The gold standard for diagnosis of Clostridium difficile is it is very simple. Stool culture is the gold standard. You appreciate the microorganisms. But another lab supports like leukocytosis with abdominal cramps and raised amount of leukocytosis with hypoalbuminemia, they are also indicative. So they are also considered as helping in the diagnosis. And the other important one is it is endoscopy. So basically what you see in endoscopy is due to this inflammatory process happens, the GI in the gastrointestinal, they have developed pseudomonomembranes. They are a yellowish fat look like layers inside the colon. They are called pseudomonomembranes layers. So they are also suggestive for the presence of a chronic inflammations in the case of CDiff. So how do you manage this patient? So what are the treatments managed? So if the patient presents with mild to moderate symptoms, we can treat him like initially non-severe, like mild. For the mild symptoms, we can manage these patients with two options. The first one is fidaxomicin or oral vancomycin. So either fidaxomicin or oral vancomycin. This oral vancomycin usually you may not find it like in the oral vancomycin in this preparation. So in our setup, what we are doing is we took the IV antibiotics, the IV vancomycins, we dilute with normal cyanide or ringer lactate or with distilled waters, and we make the patient to ingest it. So we will use the IV vancomycins as an oral vancomycin, and it is really effective. I have one patient, she came from Sudan and she been treated with a broad spectrum of antibiotics for several times, like for 21 days for another medical issue. But later on, she developed a continuous diarrhea. Then after, the patient is treated with IV, changed to oral vancomycin, and she has a significant improvement. The other one is for the case of severe. This is mild to moderate. For the case of severe ones, again we are using this oral vancomycin, but we are also IV metronidazole. But if the patient has this, we are IV metronidazole when the patient has these severe symptoms like megacolon, ileus, and perforation. If perforation, it is basically surgery, but at least megacolon and ileus, they require this one. In the case of fulminant one, again the same, oral vancomycin with IV metronidazole. The management will stay the same. The other most important point I would like to raise in the case of Clostridium difficile is about its recurrence. Since it is normal flora, once you are treating with oral vancomycin, the clinical presentation might reoccur. So we need to treat also that. So how do you treat the recurrence? The first one is, it is fidaxomicin is also a choice, and we are also treating the toxin B. Where is toxin B? The body, there is a monoclonal antibody against this toxin B called basilotocumab. They are against toxin B. Another most important and recently new thing is, here we are doing is a fecal microbiota transplantation. We are transplanting the stool with a normal flora. Will be the final management for this patient. So this is all about Clostridium difficile. Have a nice time.